So let's actually take a look at neurotrophic
let's do it.
keratitis. And that's stain without pain.
Yeah.
You know, and we have pain without stain, that's going to be neuropathic, but stain without pain is going to be neurotrophic. So let's define neurotrophic keratitis. It's the impairment of that trophic nerve supply. And what happens is the end result with that, and that's again, the afferent signal gets interrupted to the brain, which then affects the efferent signal, and that efferent signal is going to differentiate cells. It's going to have trophic factors for healing the nerves and affecting the limbal stem cells and how they differentiate and how they actually heal the cornea.
Right.
And it can affect reduced tear production because all of this is through that efferent pathway once it gets a signal. And I think the really important part that I've seen and really become much more aware of in my practice is that reduced blink rate also that occurs with the patient.
That's interesting you said that because, you do see that.
Yeah, and you know, you don't, usually you're looking at a cornea, it looks horrible and you're not really paying attention to that, but as you start treating that, you really realize. And what it leads to is spontaneous corneal epithelial breakdown, and that starts in different phases. It happens at different times it starts, and I think that's the important part of neurotrophic keratitis. Those patients are in optometric practices.
I think the key word here, it's progressive. It's a progression, people, okay? Did Brad Fundingsline wake up one day and go, I'm bald today? No, it progressively happened. And so we could have and should have intervened at some point and said, Rogaine? But no. So at what point are you going to look at your patient's cornea and say, Rogaine?
Rogaine.
Yeah.
Because it starts at an early phase, and I think our job as primary care providers is to identify it as soon as possible.
Yes.
And I think that's the important aspect. So let's take a look at common triggers that can happen. And we always think neurotrophic keratitis when we're looking at herpetic keratitis. I mean, when we're looking at HSV, HCV, we're saying, okay, well, we understand that, and what do we do to verify that diagnosis is we test corneal sensitivity, with one being normal and the other one being abnormal.
Right.
Chemical burns, the same thing. Ocular surgery, and I think we've induced this whole iatrogenic aspect of, and the thing with the ocular surgery can also be laser surgery, retinal laser surgery that affects the ciliary nerves through the application of pen-retinal photocoagulation or grid type of therapy can have that as well.
That's a good point, Doug.
Chronic contact lens use, there we go.
We talked about it. Yeah.
Chronic contact lens.
And you contact lens people, you know what we're talking about, okay? UV4 out the door, right? That's what I'm going to say.
And topical medications, of course, and that's the challenge when we know PGAs. PGAs themselves will cause a downregulation of the corneal nerves. So we know that we're using the most effective treatment for a patient to manage the glaucoma, and we're affecting the corneal nerves at a very, very high rate. Intracranial abnormalities, but again, I always say with neurotrophic keratitis, do not look for the rare, look for the ordinary.
Occam's
and the
razor.
ordinary
Occam's
is in
razor.
there.
Yeah.
Patients with diabetes, patients that wear contact lens, patients that have had LASIK surgery, had cataract surgery, look for what's in your practice all the time. You're gonna find some of these abnormalities like the intracranial abnormalities, but really what you want, don't look for the extraordinary, look for the ordinary. And when we see the diabetes and take a look at your patient population, how many patients in your practice, Mark, have diabetes, wear contact lens, and may have had a refractive surgery?
Yeah.
Huge number.
Yeah. I'm still stuck on the look for the ordinary, not the extraordinary. I think that was my dating profile. So yeah, that's how that worked out for me.
Is that a compliment?
No, it's So. Yeah, but do you know your last one there, diabetes?
Yeah.
Every diabetic patient that walks into my chair now, I do the extraordinary step of corneal sensitivity testing. Yeah. It's arduous, and it's a task that I'm willing to take for these patients.
And something that I now ask all diabetic patients is, do they have any neuropathies?
Yeah.
Do they have any problems with their feet? Do they have any? Because if they do, that's just going to be much more of a candidate at that point for neurotrophic. So when we take a look at the stages, and there's been we have just 3 stages, and even though there's other people that have been going through and they've been looking and breaking it into 7 stages, that's fine. But for the approval of the drug, there's 3 stages, and that's mild. And that is any kind of punctate keratitis that will not resolve and has a decrease and is central, that's going to be a mild. Now that mild is going to span from just a little bit to really sight debilitating.
Right.
And it stops at mild and goes to moderate when you now have a persistent epithelial defect. And now when the epithelium actually erodes, and rather than punctate, you have this large area and it won't heal. And those patients absolutely amaze me, Mark, because you look at this eye and it looks like they have this large abrasion and they don't feel anything.
My very first patient that I ever treated, neurotrophic keratitis, almost, close to 10 years ago now, he had just hit the tip of the bottle when he was putting drops in, and he just had this non-healing central that was starting to become an erosion. And the guy was the most jovial, happy old person I've ever seen. I mean, and you just, the disconnect between the signs and the symptoms were just so much. But to your point though, Doug, the Mackey system, of evaluating neurotrophic keratitis falls really short, but it's also quite, kind of simple, right? If you have decreased corneal sensitivity, you have any mild signs, that's stage 1.
That's NK.
That's NK.
And in the treatment of neurotrophic keratitis, stage 1 is approved.
Yes.
The studies didn't show that. They showed moderate, stage 2, and stage 3, moderate and severe.
Yeah.
But stage 1 is approved. And so, as we look at diagnosing, I mean, the exam and the history.
There, she put it up there. There we go.
What's that?
That. I'm pointing to Doug there. We're getting from the booth here
okay.
We're pontificating too much. Yes. You know what, Dr. Kate? People are here to hear us talk. That's why they're here, okay? Just because you helped design the slides, okay? It's about us, damn it. She wants to speed up, Doug.
Okay.
Okay.
So I think as we look at diagnosing, we're going to talk about corneal sensitivity testing incredibly, but the exam and the history will lead you to doing the corneal sensitivity. And that is, if you look at that patient and they have that recalcitrant PEK, if you look at that they're diabetic, that they've had surgery on their eyes, that they've been on a long-term contact lens wear, those are things that lead you to say, well, maybe this is because of a decreased corneal sensitivity.
Yeah, this, the Cochet-Bonnet method of doing this, it's not necessary. Clean your hands, go into a surgical practice where they bought the cheapest cotton wisps, or like cotton tip applicators, where you have to really work it. No, you know what? What is it? It's like this thing was like paper, still working it.
This may or may not have been a setup, wouldn't we?
It was a setup. It was like, you just need the tiniest little wisp. And honestly, you come at some hottie like this, who's just so happy to be there. Look how happy that woman is. She is psyched.
This patient exudes happiness.
She does. She does. You know what? Like I said, look for the extraordinary, not the ordinary. But you see the blink response and you see how you're going at it. Now, I don't do it outside the chair, right? See how the immediate blink, you didn't see it, but she punched me, like right there. She's like, stop touching my eye, and I felt a punch. So, but I do it behind the slit lamp now.
I do, yeah.
And I don't even tell a patient, I just come at them, and
there's no need to tell them.
No. And if, honestly, you could be just jamming that in the eye. I think we have your method's a little different, right, Doug?
Let's take a look at that. I use dental floss, and I'd like you to take a look at this patient. And I just come in from the side of the slit lamp, and you can see, you just touch that, and she giving this blink response.
Yeah, it's that immediate kind of like reaction. Yeah. But what happens if they have corneal sensitivity?
No, let's watch that.
Yeah,
let's see what happens when you have decreased corneal sensitivity.
Look at those eyes. That is some brilliant. Look at the eyelashes and the eyebrows. This person's lit. I'm a little concerned about that lesion by their nose, though.
Focus.
Yeah, nothing. Oh,
Focus.
sorry. Yeah, we're running. We're got to speed up a little bit.
But you can see it's all about the blink reflex and how they respond to that. So when
also, do you ask them? Did you say, did you feel anything?
No, I don't.
It's all about the blink reflex.
It's all about the blink reflex. And then when they say, "What did you just do?"
Yeah.
Then I'll tell them, and they'll say, "Oh, I can feel a little bit more on this side." But the point of the corneal sensitivity testing is do it on normal, so you know what normal is. And that way, when you have a bilateral decrease, and a bilateral neurotrophic keratitis where you have that decrease, and if they're contact lens wearers, if they're surgical patients, if they're diabetes, it's likely to be in both eyes. This way you can differentiate that each eye is decreased due to the normal. Establish your baseline. So I would say on Monday, take the next 15 patients and just take some dental floss, come in. You don't even have to tell them what they're doing because they don't know. It's not going to hurt them.
Right.
Just tell them to keep on looking ahead. And then if they do say, hey, what was that? And say, I was just flossing your eye. That's all.
Yeah, just flossing your eye.
Yeah.
But I mean, the test is ridiculously easy. It's you could be a first-year NECO student and do this.
Yeah.
I would go do it on yourself.
That's why Mark was being a bit facetious when he said how difficult it is to diagnose it.
This is honestly one of the easiest, if not the easiest, diagnostic test we do.
Second only to looking at for Demodex.
100%.
Yeah.
Look down, touch the eye, boom, we're done, people.
Yep, that's it. So amniotic membrane is some therapeutic bandage lens. I don't use therapeutic lenses anymore. There's just too many other good treatments. I'll use amniotic membranes.
I do that as a stall tactic.
Yeah.
I put an amniotic membrane as a bridge.
That's
although
exactly
there is
what I
some
do.
studies demonstrating that we can increase corneal sensitivity using like the cryopreserved amniotic membranes. But to me, cenegermin BKBJ is up there. And if you're not using cenegermin, then you're missing out.
One more time.
Cenegermin. We actually had some cenegermin at a really lovely Thai place up in Flagstaff. So.
These are some of the treatments that we have. The amniotic membranes, what we find, and I agree with Mark, those patients, I mean, that seems to be the starting point to see if you can get that because studies have shown that it will stimulate and increase density and sensitivity with corneal nerves. On the cryopreserved, I don't think that study has been done on the dehydrated or the acellular. I don't think we have seen that data yet.
We haven't.
But for neurotrophic keratitis, I will use a amniotic membrane, put it on, take a look, see if we're going to get, but I always use it as a bridge. If I'm going to prescribe Oxervate, what I do is this happens while they're waiting to get the product.
Yeah, and Oxervate is cenegermin BKBJ. Yes.
I never get tired of hearing you say that. So with the cryopreserved, this 22 millimeter ring, this is actually the full amniotic membrane. Most of the time it's the Trukera Slim with the much thinner, same tissue, everything is same, just smaller ring. And the newest research now is showing it only has to be in for 2 days.
Yeah.
And that's what I'm doing now is just put it in for 2 days. This is a study by Thomas John that shows the increase after 1 month and 3 month increase in density and increase in sensitivity for the corneal nerve. So we know it does have an effect with neurotrophic keratitis. And this is what we were talking about, the cenegermin.
Cenegermin BKBJ.
And
Do you know what the BKBJ stands for?
Yes.
You do?
I do.
Oh, okay. You can tell me later.
Okay.
All right.
And this really, it is bioidentical to human nerve growth factor. And I think that's the amazing part. And the lady that actually discovered this never got to see it commercialized. And she lived to 104, but she won a Nobel Prize.
Beautiful.
Yeah, so she...
For cancer, wasn't it? Like
Yeah,
recombinant for cancer? Nice.
So really pretty amazing. And the clinical trials, it showed 72%. Now, and the important part of the clinical trials is everything was a level 2 or level 3. So it was either
to have an abrasion or an ulcer.
Yeah, it was a persistent epithelial defect or an ulcer. And of the 72% that healed, then 80% of the patients remained completely healed 1 year after completing the therapy. And I think that was impressive, and that's what led to the FDA approval.
I think this is even more impressive,
Oh yeah, the 4-year retrospective study. Yeah, tell us about that.
No, it's a single 8-week treatment, which is what we normally do for cenegermin BKBJ. And over 48 months, they found significant improvement in visual acuity, tear production at 1 year, 2 years, and at 3 years. And the corneal sensitivity improved by about 1.5 times from baseline. So it definitely demonstrates that you're making a difference. We don't utilize cenegermin BKBJ enough in our practices. So hopefully, and if there was a question here, would you consider using it more often? The answer should be yes, okay? We keep getting further and further behind, Doug. Do you notice that?
I know.
But you know what?
Corticotropin gel, make this quick. This is for those patients that don't even respond to nerve growth factor. Have you used this at all?
I have, but not. I think you've used it a lot more.
Yeah, and it really is. I mean, these are the patients that are so desperate, and really it's a release of corticotropin gel. It's injected twice a week, 80 milligrams, and it's going to be. I mean, I have patients on it that now have been on it 9-10 months.
Yeah.
And but I have seen amazing results, and basically it's even patients that have failed with steroids and systemic steroids. This is a means of getting having some of the corticotropin release. So